Breast cancer is a global cause. Globally, considering the data of GlobalCan, which is a WHO database that enrolls all cancer types every year, has revealed to us that it is the first globally in terms of incidence and prevalence. And in Rwanda, it is the first since considering the data of Rwanda Cancer Registry of 2022. This year we have recorded more than 660 around of patients that got breast cancer. These are cases that got symptoms diagnosed and current on treatment, others waiting some modalities of treatment because breast cancer treatment requires different modalities of treatment, including surgery, radiotherapy, chemotherapy, and other types of treatment that we call hormonal therapy. However, our data we were predicting to have around 1,200, which means that, first of all, the problem is there. We have it here in Rwanda. However, the number of patients that reach to the treatment centers is still low, which may be associated with different factors that we can name, among them including low levels of awareness in our population. Second may be what we call maybe health system delays, because when even our patients reach local community healthcare providers, meaning health posts, health centers, they are not aware of how this disease present, and they may delay in transferring to reach to care. But also there are other social-cultural factors which sometimes people ignore. It is a major problem because a mother or a father, because breast cancer can affect men or women, they may get some of these symptoms. They consult traditional healers than consulting healthcare professionals, as we know. I am by profession an oncologist, meaning a doctor who treats cancer. And I work at Rwanda Military Hospital in the department of that treats cancer, of course, called Rwanda Cancer Centre. And I'm representing also the cancer program at Rwanda Biomedical Centre. Breast cancer is common to women at more than 95%. However, evidences and data that are available that have been shared by WHO agency, which is GlobalCan, so that it is less than 5%. In Rwanda also, we have this common issue. For us, more than 95, 97, they are women, but also we have some men which who are on treatment, being chemotherapy, radiotherapy, surgery, and they are few compared to women at around 3%. The data that we have from 2007 till now, when you look at our graphs, they keep increasing. You can see the increase in the prevalence and even new cases that we see, which is the incidence. And also to mention here, people to understand, we are finding that data reveal that breast cancer also is the first to show up with the very big number of patients who die, the first in mortality and even morbidity. Unfortunately, also it is taking people of young age, between most 70% between 40s and 50, people at still young age. So the increase may be associated with some factors. One, considering maybe since 2007 you had only one pathologist who is like one of doctors that help in diagnosis. By this time we have more than 20 pathologists. We didn't have more than one oncologist. Now we have more than 10 oncologists. Doctors who can do surgery for breast were few. which is among the first factors that people don't think about, why it is a major one. Because for people to know that they are sick, they need to be diagnosed. So I am saying this to say that even if in 2007 we didn't have a very huge number of patients, our data show that they were few, it is not because that they were not there. They were there, but they were not diagnosed. That's one thing. But also we couldn't forget the lifestyle that is changing, according to what we see as maybe risk factors, because the breast cancer cause till now is not yet known, but there are what we can call like risk factors. One may be, obesity, that we say about, because it has been revealed that obesity is one of risk factors. Nulliparity, yes, nulliparity, meaning that without having any pregnancy. Also late pregnancies, having the hormonal contraceptives. These are some conditions that we are living in that previously were not common. So as now the lifestyle changes, we may expect a lot of, a huge increase in prevalences and incidence of breast cancer. So those may be a factor associated with this. But the major one we should name about this increase of healthcare providers who now can, diagnose. The third one is about the awareness. In Rwanda there is a saying that we say commonly in English that when you want to cure a disease, first of all, you have to reveal it. So people were not consulting. People were not sensitized. And maybe to help people to understand more, we can remember in years like 2002, when, for example, the case of HIV was not yet sensitized. People were not, going for screenings, even if also the treatment was not available. So due to that, it was a major challenge. So we hope that also as we keep the sensitization, mobilization, people will keep doing like early screenings, and then we treat them, so the issue will be solved. The early signs of breast cancer, you may look at your nipple or someone's nipple and you find that it is retracted. Or you may see something like ulcer, which is not healing, that also can, pinpoint you to think about any unusual sign on someone's breast. So when you see one of those or any unusual sign on breast or in axilla, that may be giving someone high index of suspicion to go for consultation. And then when you come to us, we first of all ask you some questions. We ask questions about how this occurred, since when, and also we deep deeper to go in a family relations from your father's side and your mother's side to know if there is any history of breast cancer disease. And also we ask some questions ruling out any history of known breast cancer risk factors. When you have put together all those information that you have given us and what we have seen during inspection to see your breast and comparing them, and then we do what we call palpation. We feel any mass on someone's breast or axilla that can give us high index of suspicion, and then we'll take you to some preliminary examinations. The preliminary examination that we do, we first of all, when someone is less than 45, we start by doing what is ultrasound. It's a device that we will be putting on a breast to see the consistency of the breast mass, the breast, to see if there is any unusual mass. The mass may be plain or fluidish, and then we grade that mass or fluid that you see there, because the grading can give us maybe high index of suspicion combined to what we have seen during the clinical examination and history. If we find that the mass also is orienting to what is known as a cancer, we do what we call biopsy. It's a way of like taking what we call like fine needle, or we do core needle aspiration, which is a device that we take, put in someone's breast. We pull some small amount of cells, we take them to the laboratory, and then this will be analyzed under the microscope by doctors that we call pathologists, who read those cells and tell us if those cells are becoming cancerous or not. And if we find that they are becoming cancerous, then now we can start telling to the patient that he or she may be having, or he or she has cancer. After that, we needed to know this cancer which is in someone's breast, because the cancer development in nature, it has like ability to move from the primary site now, which is the breast. It may leave the breast to the liver, to the spinal cord, to the bone. Okay, it may go in the other area. It may go in the brain and elsewhere. So to look at that, we request you some investigations like CT scan, which scans the whole body. We may, depending on what signs that we are seeing, we may request the CT scan from head to see if maybe it is not in the brain, depending on what you have shown us, told us also. We check your chest, go in abdomen, and then if we have screened and we found that the disease is on the breast only, there is modality of treatment. Communication about cancer diagnosis is not as such easy, because not of being a disease, but because what we expect, that's what we expect after the diagnosis. So in our common practice, when someone has been diagnosed with cancer, first of all, we take a specific time for delivering what we call a bad news, first of all, to the concerned patient. Sometimes there are those who may not sustain to accept the bad news. It may even take some days to understand it and to accept it. And there are those who accept the diagnosis to be delivered to the family members, or those who don't. So first of all, the first step is to ask the concerned if he or she is conscient about that, to give the permission for the family members to know the diagnosis, because they are the one who will support during the treatment. And then we need also time. We have a team which is expert in information, about information supporting patients. So we make a team of a doctor, psychologist, sometimes nurses, and it is not commonly, and other colleagues. We go in a very safe environment that is reassuring. Then one of the team will sit with the family members to comfort, first of all, and then we tell the bad news, we tell about the diagnosis, we talk about all those processes that the disease goes through, and then what is the planned treatment, what we'll be doing, and what is the time expected for the management. And when it is even something worse to happen, sometimes we alert them. Stage 4 breast cancer is a very painful diagnosis. When the patient presents to me with such kind of condition, first I feel him or her, and the first thing I do it's revealing the bad news, but it requires some form of compassion. First of all, we need to put someone in reassurance that we can do something, because most of them they'll be in metastatic phase, whereby the disease has spread to all over the organs, and now we can do something which is now prolonging life, improving quality of life, reducing pain, supporting psychologically the patient and the family, knowing that being diagnosed of stage 4 disease, especially breast cancer, it's not the end of life, because even if one or two people may present at the same stage, but the behavior of the disease may not be the same, and then we get profit from this to seek treatment that can assist people to prolong their life and survive well without compromising their hope of living. When we are treating a cancer patient, we have to assess different things. Among them, it's about the consent of the patient, because the way the cancer behaves and the treatments, being surgery, radiotherapy or chemotherapy, those are heavy treatments that requires someone, a very, huge commitment. Someone has to accept it, but they accept it having been told the advantage, the outcome expected, the intent of the treatment, but also the side effect of the treatment modality. So the consent, the first one. But also there is now the role of doctor. We need to see if the body of the patient that is going to undergo the treatment can sustain. Because if this surgery, someone may sustain the anesthesia. Someone may be having the normal physiology, means normal blood count. They may not be having the chronic disease to sustain the anesthesia and even the operation as such. For radiotherapy also, there is what we call performance status. Someone needs to be fit to go on radiotherapy, because there are some effects that comes with when someone is not physically fit. But also, we need to consider the effect that it may cause. So there are some diseases, but here for the breast, it is not common, but there are other diagnoses whereby we found that the expected outcome from the treatment which is being posed and the effect may not be good. When we found that the effect is worse than the outcome, we don't go for that, and we tell the patient we balance. We opt sometimes to go for surveillance, and then we expect the outcome, meanwhile comforting the patient. But those are some of the issues we have to take account. But also for the chemotherapy, for example, we know the chemotherapy is a drug, and when it is administered in the body, it has to go throughout some important organs like the liver and the kidney. And also we should take account of the blood throughout which it passes through. So when someone doesn't have very good, blood, component of the blood, they are not in a good range, normal range, we intend to tell the patient what happens, and if there's something to be corrected, we correct it. Then someone may be put on chemotherapy. A patient shouldn't be in huge pain. We are here to help them. We do, as a chronic disease, we have to identify the pain. The pain may be psychological to mean associated with the bad news. Someone is feeling in him or herself that he's suffering from severe disease, which may not be curable. So when you see someone with cancer, normally, without even complaining, in themselves they're suffering. That's why we need to be associated with them, to approach them very compassionately, to reassure them, and to give any assistance that is possible, being physical, psychologically, and psychosocial one. Second, the pain, which is physiological, we grade it. There is a scale of the pain, and then depending on the scale of the pain, we give a specific pain medication to make sure that the patient is well, doesn't feel pain. There are those who get severe pain, which may not be supported by usual treatment. So we keep scaling up the treatment according to the pain, the level of pain, and the strength of pain medications. And here in Rwanda, most of them we have, and there are those which may not be affordable easily, so the government provides for free. That is an example of morphine, which is available in all cancer treatment centers, and it is given for free for our patients. Breast cancer is a global issue, is a global cause, and Rwanda is the very first prevalent cancer and first in morbidity and mortality. Unfortunately, it's affecting our young mothers, sisters, and men. It is an issue that can be, it is a disease that can be cured if it is found at early stage. In order to mitigate it, the government of Rwanda, through Rwanda Biomedical Centre, has put much effort in awareness and screening to make sure that people from the community identify the early symptoms, get referred for the treatment. The good news is that when you are found with early stage, you can be treated curatively, go back to your normal life. So there is a good hope. We have all treatment modalities in Rwanda, being surgery in all university teaching hospitals, Rwanda Military Hospital, King Faisal, and the Rwanda Cancer Centre of Excellence. We have radiotherapy, which is in Rwanda Military Hospital. We have chemotherapy that can be found in Rwanda Military Hospital, King Faisal, and Rwanda Cancer Centre of Excellence. Also thinking to expand it in Kigali University Teaching Hospital and Butare University Teaching Hospital. So all those are the facilities that the government of Rwanda has put in place to make sure that any Rwandan, whoever is, can be treated and go back to normal life. So please, let's be aware, all of us, go for screening, and as you get screened, you go for treatment with hope to be cured.